afternoon, everyone. Let me introduce my PhD topic about the management of postoperative complications after third molar removal. My name is Eszter Hardi, and I am a second-year oral surgeon resident at the Department of Oro-Maxillofacial Surgery and Stomatology. My vision as a PhD student is to improve the life quality of patients undergoing oral surgeries, and my mission is to find the best solution that alleviates patients' complaints after the third molar removal. To achieve these are my current specific goals. My goal is to bring the twin mix and the kinesiology tape into the everyday oral surgery practice. My first project is about the effect of perineural twin mix injection in reducing postoperative complication in lower third molar removal, which is a systematic review and a meta-analysis. Why is it important? Well, I'd like to present some interesting data to demonstrate the importance of this topic. Wisdom tooth removals account for 90% of oral surgery procedures, including simple extractions, and impacted lower third molar is found in 90% of the general population, and about 85% of the third molar will eventually need to be removed. And after this surgery, in the first 7 days, patients have trismus, swelling and pain, but their degree, of course, can vary. So my question is, how can we reduce these symptoms? Well, a twin mix anesthesia is a novel technique for mandibular anesthesia. What is twin mix? It contains local anesthetic solution and steroid, which usually dexamethasone. How it works? Addition of dexamethasone inhibits the action of phospholipase A2 and the release of arachidonic acid, decreasing leukotrienes and prostaglandins, render the final pH of the mixture more basic. So the increasing the pH decreases the pain, shorter onset, and longer duration of anesthesia. So my aim is to assess whether pain, swelling, and trismus following surgical removal of the third molar can be reduced by perineural twin mix injection. My clinical question is perineural twin mix injection an effective adjunct therapy in reducing postoperative complications in third molar removal? I use the PICO framework, where P is patients who underwent mandibular third molar removal. Intervention is twin mix anesthesia plus standard treatment, and comparator are conventional anesthetic solution plus standard treatment. Here, standard treatment means that dexamethasone is not used. Amoxicillin, clindamycin, painkillers, or other regular medications are prescribed for postoperative complications. And my primary outcomes are swelling and trismus, which are measured in millimeter. And my secondary outcomes are postoperative pain and pain score on the local anesthetic injection, which are measured on the visual analog scale. And the others are the duration of soft tissue anesthesia, which is measured in minutes, and the latency of anesthesia, which is measured in secondum. My hypothesis is that perineural twin mix injection can reduce pain, swelling, and trismus after mandibular third molar removal. And my clinical implication is to reduce these postoperative complication symptoms and to reduce patients' discomfort with the injections. We did a systematic search in the main 3 databases with this search key that you can see on the slide. After the full text selection, we have 8 eligible articles. And here you can see my first project progress. As you can see on the slide, I finished with my data extraction table, and now I'm working on the ROB. My second project is about the effect of kinesiotape as adjunctive therapy in reducing postoperative complications in third molar removal, which is a randomized controlled trial. How I mentioned before, after the third molar, lower third molar surgery, patients have trismus, swelling, and pain. And with the standard treatment, these postoperative complaints are present to the same extent. So my question again, how can we reduce these symptoms? We always suggest the cryotherapy after the surgeries because it produces vasoconstriction, controls bleeding, and decreases of tissue metabolism. In addition, a new technique appeared, which is the kinesiology tape method. How it works? It leads to the activation of mechanoreceptors by causing pressure, improving blood and lymph circulation, and it has some advantages because it's non-invasive, cost-effective, and continuously active throughout the entire application period. So my aim is to assess whether pain, swelling, and trismus following surgical removal of the third molar can be reduced by kinesiology tape. My clinical question is Is kinesiology tape an effective adjunct therapy in reducing postoperative complications in third molar removal? I like to use the PICO framework, where P is patients undergoing mandibular third molar removal, and I like to compare the kinesiology tape with 20% tension and with 40% tension, and the wound tape with no tension as placebo. And my primary outcome would be the swelling and the trismus, and my secondary outcome would be the pain, the painkiller intake amount, and the kinesiology tape discomfort and the quality of life. My hypothesis is that kinesiology taping with 40% tension is more effective than other tension and placebo in reducing pain, swelling, and trismus after mandibular third molar removal. And my clinical implication is the same, so to reduce the postoperative complications. I like to include patients who need unilateral lower wisdom tooth removal, and I like to exclude patients with systematic disorders and patients who have sensitivities to the tape. How I mentioned, I like to compare the kinesiology tape with different tensions and wound tape with no tension as placebo, and I like to apply the kinesiology tape from the trigoscaleon line to the supraclavicular lymph nodes. On this picture you can see. And in all cases, patients should use the ice pack for 10-20 minutes several times a day with quarter-hour breaks, and of course with a break at night. And the single operator would perform all surgical procedures, and one person would apply the tapes. My primary outcomes would be the swelling and the trismus. In case of swelling, I like to perform volume measurements with the Prophase system and the 5 lines measurements on the face, which will be measured in millimeter. And in case of trismus, I like to measure the maximum interincisal distance in millimeter. And my secondary outcomes would be the pain, which will be measured on the visual analog scale. The pain others is the painkiller intake amount, and I like to assess the kinesiotape discomfort and the quality of life with questionnaires. So currently I'm working on these 2 projects, and I plan to finish these by next summer. And I like to thank you for your attention with a quote: "A goal without a plan is only a dream." Thank you.
So you mentioned that in your clinical trial you will use kinesiology tape, yes? And you mentioned that you will use 2 kind of percents, 20 and 40%. And my question is that how did you choose these 2%? And you mentioned that you will put the kinesiology tape on the side. Mm-hmm. And how did you decide where to put it? So this is...
Yes, I go back because we have kinesiology tape tension guidelines, and based on this, I decided the tensions, because here you can see on the slide that with less than 25% we can achieve reduction in edema, swelling, and with less than 50% tension we can reduce the pain. So this is why I choose these numbers. And I choose this kinesiology tape method because unfortunately we don't have guidelines about it, but this was used in most cases, in the most article, and well, I think this is the best one, because the largest edema can be seen on the tragus commissure line, and edema is leads through the neck lymph nodes.
Thank you for the presentation. My question is about your first topic. So, do you think would it be feasible to investigate the efficacy of this twin mix anesthesia in other dental procedures? I mean, other than third molar extraction?
Thank you for your question. Yes, of course, absolutely. I think we can, we could measure it. So yes.
Hi, I have a question about your second topic. I was wondering if how do you plan to deal with the different grades of difficulties that lower molar removal has, because there are some easy cases where you can remove it, or there are cases that are harder, maybe due to the angulation of the molar, or if it's inside the bone, or...
Yes, thank you for your question. In all article, they use the Peg-Gregory classification, and according to the Peg-Gregory classification, level 2, class B, which they used. So it's the same in all cases. Thank you.
In your first study, we are talking about an intraoral injection of dexamethasone, right? Yeah. Well, you know, steroids, they used to be quite common in using every type of inflammatory situation, but more and more we are realizing that maybe the risk and benefit is not so good. And that's why I would be very curious in your study to see some safety outcomes. So adverse events associated with the use of steroids, because we do have alternatives to topical steroids when it comes to inflammatory mediation. So maybe adding, for example, the incidence of candidiasis or any other systematic complications as a safety outcome. I think that will be also very interesting for the readers and the reviewers as well. Just a comment.
Okay, thank you.